Okay, let's move on to maintenance. Gareth, you've been leading the way here with a large trial. Tell us about that and what has taught us about maintenance therapy with lenalidomide.
So I think it was the final piece of evidence that really supports the use of Revlimid maintenance compared to no maintenance. So the standard of treatment.
And this was a 2,000 patient trial, is that right?
So approximately 1,000 patients in each arm. There was an improved PFS. We should have an OS benefit data by
improved
the end of the
PFS
year.
was actually almost a doubling, if I recall rightly.
Yeah, so the hazard ratio was 0.43, so a really good hazard ratio. I mean, amazing difference. And I think the additional data it provided was it works across all subgroups of risk.
You also looked at duration of therapy and had some interesting findings there, because this has been a controversial question. Do you treat for 1 year, 2 years, 4 years, forever?
So for the people that fell off treatment for reasons of toxicity or otherwise, it seemed that if you fell off in the first year, you did worse than if you fell off the second, and if you stayed on for 3 years, it was.
So your recommendation is lenalidomide until progression, or lenalidomide
I think
for?
you have to. That it should be the guideline recommendation, because that's what the data is derived from.
Practically speaking, Tom, that's sometimes hard to do. What percentage of your patients do you think can stay on forever?
So at UCSF, we just had a pharmacist looked at our data, and during the maintenance phase, the thing that patients became toxic was from fatigue and also from diarrhea. And so the average duration of therapy was between 2 and 2.5 years.
And that's kind of my experience too. Sagar, what do you think?
Yeah, I mean, I think we try and push to that first year based on, without knowing your data, but with knowing the French data in the maintenance setting, where at least they seem to do better. But I mean, I think if you use the medicines to prevent the cholesterol,
and cholestyramine,
that can make a big difference on diarrhea and can keep patients on for a long time.
Okay, what about other drugs in maintenance? So it sounds like we have consensus that lenalidomide is being used routinely. Other drugs you use in maintenance?
No, not as standard of care.
Saad, you use bortezomib in maintenance?
Yes, for the translocation 414 patients, we had those.
High-risk patients?
Yes.
Anybody else using bortezomib high risk?
So we use the combination of both, the Revlimid, Velcade, for 3 years, fixed duration. We managed to get most people through it.
Right.
What do you think is coming in this space? Are there drugs that excite you in the maintenance setting, Sagar?
So I think the only caveat to the bortezomib len in the maintenance setting is patients that have not achieved a VGPR before transplant, which foretells you that they're probably not as sensitive to VRD and they're high risk. And so for those patients, we actually give carfilzomib and pomalidomide in the maintenance setting for 3 years, as you described.
So absolutely.
I think the antibodies, though, are going to make the big splash. And I think, obviously, there's emerging data from a couple of trials looking at daratumumab in the maintenance setting, and the Germans have a really interesting trial looking at elotuzumab in the maintenance setting.
So that's a perfect segue into what's coming. What's coming for therapy that people need to be aware of?
In the upfront setting, I think there are 2 abstracts being presented looking at the triplet plus antibody combinations. So we have KRD daratumumab being presented and RVD with elotuzumab being presented at ASCO this year.
And what's your take on those 2 abstracts?
So I think the KRD dara, I was part of both the studies. With KRD dara, this was a safety and tolerability phase 1. And it appears that we don't see any new cardiopulmonary or other signals from the safety perspective. Overall response was impressive. The K dosing was weekly, which was better tolerated.
K being carfilzomib for the
yes, for
people listening in.
And I think that the data will be reported later, but the depth of response is very impressive.
Okay, what about the elotuzumab? Do you have a chance to look at that?
So I saw the abstract. It looks like there is evidence of responsiveness. Certainly,
100% response rate.
100% response, yes, with a very favorable toxicity regimen. I think, I mean, this is new of using. I think what has been a problem with elotuzumab thus far is really testing it in an unpractical patient population, and upfront Revlimid naive patients are probably much more available than a relapsed Revlimid naive patient, as was in the Eloquent trial. And so showing that a lenalidomide naive patient can actually respond well and that can be consolidated with ERD, I think is looking very promising.
Anybody else? Were you part of the elotuzumab study? What was your take on that?
Yeah, I mean, I think it certainly was, we've got a number of patients that are pretty far out. I think one of the concerning signals, just to be perfectly honest, is that there were 2 deaths in the trial. Both of them occurred early on. One was an infectious
2
complication.
out of 42 or something?
Yeah, something along those lines. One was very early, and one occurred after the patient had come off study. Both were infections. Both were elderly, transplant-ineligible patients, frail patients potentially. But the young patients seemed to have done quite well, and there was no issues with stem cell collection.
People think antibodies are going to be part of our standard of care fairly soon.
I think they are already.
Well, newly diagnosed
Yeah,
patients,
upfront.
not yet, right?
I mean, there's
if
4
you can
large
get it.
frontline trials, right? So
Right.
4 large frontline trials testing daratumumab, lenalidomide dex against lenalidomide dex, elotuzumab lendex versus lenalidomide dex, carfilzomib lendex versus Velcade or bortezomib lendex, and exazimib lenalidomide
So
dex.
more data to come.
So it'll be really, I think, exciting over the next 2 to 3 years on what we're going to choose for frontline therapy. And I do agree with what Yvonne said, is that, you know, the elotuzumab is very well tolerated in frontline therapy in lenalidomide naive patients. And in fact, I think Sagar said it earlier too, in the frail patients, despite what you just said about the early deaths and the infection, that might be a really great regimen for the frail patients.